Right now, ma'am.
So a hearty welcome to all the postgraduates present here. Good evening and welcome to our VGM academic meet where today is a clinical pathological discussion. We've decided to do a clinical case which Dr. Karthik, our DNB resident, will be presenting. And then our expert, Dr. Balan sir, will be dealing with the pathology part. So totally feel free to put up any questions you have in the chat box in the YouTube and we will answer it at the end. And hope you have a very enlightening and entertaining session today. Thank you. Thank you for joining us. Stay tuned. Yeah. Karthik, you can start the presentation.
Yes.
Balan sir,
Good
you want
evening.
a word?
Yeah, let him start.
We'll start the presentation. Sure.
Yes. Good evening to one and all. 56-year-old female came with chief complaints of disturbing generalized itching with nocturnal predominance
Can
since
you
10
put
years.
the mode as PowerPoint mode?
Yeah,
So that full screen. I mean, in the full screen mode in the PowerPoint. Sure. Exactly.
A 56-year-old female came with chief complaints of disturbing generalized itching with nocturnal predominance since 10 years on and off. Pale colored stools noticed on and off since 10 years. Weight loss. She's of 80 kgs initially and she reduced it to 40 kgs over the past 5 years. Easy fatigability since 1 year. History of fever, anorexia, malaise, followed by yellowish discoloration of eyes and urine, which are gradually deepening and not fluctuating from past 6 months. She noticed a distension of abdomen and bilateral lower limb swelling 3 months ago, for which she took native medicine and symptoms got resolved in 1 week. Right now, her complaints are again the distension of abdomen, leg swelling, nausea, vomiting since 1 week. She gives a history of small joint pains on and off type since 10 years. And she also noticed foreign body sensation in eyes and dryness of mouth. There is no history of hematemesis, black sticky stools, no history of altered sensorium, sleep is normal, appetite is normal, bowel and bladder are normal. Past history, history of contact with tubercular patient, no history of hypertension, diabetes, asthma, heart disease, seizures, no history of abortions, preeclampsia, no history of blood transfusion or tattooing, no history of recent travel, no history of previous abdominal surgeries. Family history nil significant. On general examination, patient is thin built, nourishment, there is narrowing of temporal groove. There is prominent malar prominence and there is supraclavicular hollowness. Height is 152, weight 39 kgs, BMI is 16.9. Her blood pressure is 80 by 50 millimeter of mercury, pulse is 68 beats per minute, RR is 18 cycles per minute. On examination, pallor present, icterus present, no fetal hepaticus, no spider nevi, palmar erythema present, clubbing present, there is shiny nails, no debuterance contracture, no flapping tumors, feeder edema is present. On systemic examination, coming to inspection, the abdomen is uniformly distended with full flanks, umbilicus is flattened, corresponding segments of abdomen moves equally with respiration, no any distended veins, no visible gastric peristalsis. Stria are present, no scars and sinuses are seen, hernial orifices are normal, genitals are normal. On palpation, there is no local rise in temperature, no tenderness, liver is hard, nodular, both liver lobes are enlarged, liver span is 6 centimeters from the right costal margin. Spleen is firm 6 centimeters from the left costal margin. Xiphisternum to umbilicus, the distance is 16 centimeters, whereas from umbilicus to pubic symphysis, the distance is 12 centimeters. The ratio of upper segment to lower segment is more than 1. Abdominal girth is 68 centimeters. On percussion, shifting dullness is present. Auscultation, bowel sounds are normal. There is no hepatic bruit, venous hum, splenic rub. Other system examinations, cardiac is normal, respiratory system, chest is clear, CNS is normal, no focal neurological defect is noted. Provisional diagnosis, based on the above complaints, decompensated chronic liver disease has evidence by jaundice, ascites, pedal edema with intrahepatic cholestasis, non-bleeder, no hepatic encephalopathy. Probable etiology will be primary biliary cirrhosis, primary sclerosing cholangitis, overlapping of primary biliary cirrhosis and autoimmune hepatitis, CAM-induced vanishing bile duct syndrome, idiopathic ductopenia of adulthood, disseminated tuberculosis, infiltrative liver diseases like lymphoma, amyloidosis, sarcoidosis. Investigations, total bilirubin is raised 19, direct bilirubin is 16.4, SGOT is 138.1, SGPT is 36, alkaline phosphatase is 110.9, serum proteins are 7.9, albumin 2.7, globulins are 5.2. Complete blood picture, hemoglobin is 9.9, white blood cells are 8,190, RBC counts 2.8, platelets 1.36, polymorphs on the higher side 81.1, lymphocytes on the lower side 9.9, eosinophils 0.9. Blood urea is 24, creatinine is normal, sodium is 125, potassium is 4.9. Prothrombin time is 14.7, INR 1.2, GGT is 27.8. Ultrasound abdomen reveals chronic liver disease with portal hypertension, mild, it's mild splenomegaly with grade 1 esophageal varices. AMA M2 is strongly positive, it's 3 plus, IgG is positive 31.84. ASMA is positive, ANA is positive, LKM1 is negative. Thank you.
Balan sir, so that ends the history and the investigation part.
Okay.
If you have any questions to ask him.
So at the end of investigations, your provisional diagnosis was PBC AH overlap. So with that, the biopsy was done, correct?
Yes, sir. Yes, sir. Exactly.
So we'll go ahead with the biopsy. So now I think you are able to see my screen, correct? Can anyone confirm that you were able to see my screen? Okay. So now this is the H&E stain of the liver biopsy. So this is one portal tract with fibrosis. This is again one portal tract with fibrosis. Portal tract with fibrosis. So basically we are having portal tracts per se. We are able to appreciate the portal vein, whereas we are not able to see any clear-cut bile duct. So bile duct is completely obliterated. So this is a vague bile duct which is completely obliterated. And in addition to that, we are having a lot of inflammation. The inflammatory cells are mainly lymphocytes and a few plasma cells. Every portal tract has similar infiltrates, similar kind of fibrosis, loss of interlobular bile ducts, and portoportal bridging. So this is again a regenerative nodule formation. Here we can see. This is a regenerative nodule. So in the liver parenchyma, what we are seeing predominantly is we are having hepatocytes which are showing feathery degeneration through diffuse feathery degeneration we have, and in certain areas we have canalicular cholestasis, especially zone 1 canalicular cholestasis. And if you can appreciate here, there is also a Mallory hyaline. So this is what I was, this fluffy eosinophilic material in the hepatocytes, Mallory hyaline, especially around the zone 1 hepatocytes. So we have, so far we have portal tract which is showing inflammation, loss of or destruction of the interlobular bile duct associated with especially zone 1 Mallory hyaline, portoportal bridging fibrosis. This is the Orson stain. So Orson stain is a versatile stain. It is used in many conditions. It stains elastic fibers. It stains hepatitis B surface antigen. It stains the copper binding protein, right? So these are the typical cola colored granules which indicate that there is colate stasis, not cholestasis, colate stasis. And colate stasis occurs in chronic cholestatic liver diseases. So whenever we see this, especially periportal or zone 1 hepatocytes, presence of granular cola
I'm very sorry. I think sir got disconnected, but we will get back soon. Few minutes.
மேம் சாருக்கு கால் பண்ணிட்டு இருக்கோம் மேம்.
Sure, Regina. So sorry for the delay. Few minutes. Meanwhile, please put up your questions in the chat box, and we will ask Balan sir to answer them for you. So this patient has been on our follow-up, and we saw her even today. We have just started her on treatment, and we'll give you the follow-up, her follow-up in the subsequent sessions also. One thing I want to put across to everybody is it is not very difficult to recompensate a decompensated cirrhosis. And if you can do that, then you might end up changing the entire prognostic timeline of the patient. So this patient, we have recompensated her, and therefore I think the prognosis will be on a much better scale than what would have happened if she had been decompensated and gone to spontaneous bacterial peritonitis, which will significantly reduce the survival of the patient. So in these patients, I therefore really ask all of you to advise them on strict salt restricted diet, and small exercises that they can do, improve the muscle strength, give them a complex carbohydrate snack at night, make them recompensate, put them on a high protein diet also, and please get them back to a recompensated state. So thank you for the patience, and give us few seconds to get this set right. Sir, welcome back, sir. And this is on a YouTube link for all the other viewers. So only the faculty link is here. So you can hear us, sir? Are we audible? Sir, are we audible?
Sir is not connected, ma'am. Voice is not connected.
Okay.
Sir, you are muted, sir.
Sir, I think you have to connect to the audio. We are not able to hear you. Sir, we are not able to hear you.
Sir, you are.
Am I audible now?
Yes, sir.
Yes, sir. Perfectly well.
Okay. Madam, I was showing the slides. Till which slide you were able to see, ma'am?
Sir, up to collate stasis.
Okay. So that should be fine. So I have covered everything.
Yes,
So
sir.
to summarize, we have portal bridging fibrosis, which indicates which is basically indicating a biliary pathology. And in the portal tracts, we have a destruction of the bile ducts. We have inflammation, zone 1 colate stasis, mallory hyaline, and put together with your clinical history of AMA M2 positivity, we are dealing with the primary biliary cirrhosis. So this is one part. The autoimmune hepatitis part can be explained by presence of plasma cells in the portal tract at places there were a few lobular inflammation, and clinically globulins were elevated and the ANA was positive. So the major component in this case, I would say it is a PBC. The additional component would be autoimmune hepatitis.
Sir, few doubts from our side, sir. So small duct PSC is definitely ruled out, no, sir?
Yes, madam, because small duct PSC, if at all it happens, it will produce a different kind of picture, unlike what we are having here.
Sir, and the histological activity index was only, I think, 4 on 18. So that means the autoimmune part is not predominant.
Correct. It is not predominant. The major component is the biliary component. That is why we are having a portal bridging fibrosis. If at all, if it is autoimmune hepatitis which is causing cirrhosis, it would be more of a portocentral bridging fibrosis.
Portocentral. And this is surely not idiopathic ductopenia of adulthood also, no, sir?
Definitely not, because we are having a lot of inflammation.
Inflammation also. Yes, sir. Yes, sir.
So, that is again odd. And idiopathic ductopenia of adulthood, we won't have whatever findings which we have discussed now at present.
Yes, sir. Thank you very much, sir. I'll just check on the YouTube whether there's any questions in the chat, and I'll get back in 2 minutes.
Sure.
Sir, I think there are no questions as of now, but maybe as people see, they might put up questions. And then if there are any, I'll get it back to you on the next session, sir.
Sure, sure, ma'am. Sure.
Thank you very much for the wonderful session, sir. It was very clear. I think the histopath images were amazing. And I think even in the national forum, everybody was appreciating your histopathology, sir. So I think hats off to it. Sir, any significance for collate stasis, sir, or just indicates the severity? That's the only thing, no, sir?
Madam, in Orsenstein, whenever we are finding this color-colored granules, usually we see in case of excess of copper binding proteins. So the copper binding proteins may increase in, as you know, like Wilson's disease, Indian childhood cirrhosis, which we see in PGI. I've not seen here. Then we also see in chronic cholestatic liver disease, any chronic cholestatic liver disease, especially like in this case PBC. So it actually helps. So in addition, Mallory hyaline also, it's nothing but a degenerative material. Along with the other components of the biopsy. For example, there is destruction of the bile duct. So everything put together, we are coming to a conclusion that we are dealing with the biliary pathology and not a Wilson's disease or Indian childhood or cirrhosis or something like that. So in this particular case, combining all the features put together, we say that it is a biliary pathology. If the biliary pathology is not there, only it is an isolated finding, then we will think in lines of Wilson's disease, especially with Mallory hyaline. Then if there is a component of ASH or NASH, we'll think about NASH, or where the alcohol history, we'll think about alcoholic liver disease and so on. But in that, we'll usually have Mallory hyaline. Usually it doesn't produce this color colored granule in ASH and NASH. Whereas in Wilson's, it will have both color colored granules as well as Mallory hyaline. So both can be there. So these are the things. These are the things which we look at biopsy. We take things all together, not an isolated finding. Just like, for example, Mallory hyaline is there, we think of lot of DDs. Copper binding protein, we have lot of DDs. And similarly, loss of bile duct, we have lots of DDs. And then all the three features put together, what are the DDs? Or two features put together, what are the DDs? We narrow down like that. Then especially in these cases, we look into the clinical history. In this case, there is AMA-M2 is definitely positive. It is a female patient around 60s, in her 50s to 60s. So typically, it's a very classical case of PBC. So when you give me the history, I can sign it out as PBC. If I don't have the history of AMA-M2 positivity, if I don't have the history of ANA positivity, then I cannot directly say that it is autoimmune, or I cannot say it is a PBC. In this case, I can say that it is a biliary cirrhosis secondary to PBC. So that is how your history helps to sign out my final sign out in this case.
Thank you very much, sir. That was very, very enlightening. Thank you very much. And yes, sir, hoping to see you in future with more interesting cases also. Thank you so much for your patience, and thank you.
Thank you.
Thank you, Ebenezer, for giving us this session, and thank you one and all for watching. We'll see you in future for further meets. Thank you, sir. Thank you, everybody.
Thank you.